Hi, good morning, everyone. We are on 7th of February 2026, and we are live for a very, very important session. We have Dr. Dravid. He's a leading consultant in HIV medicine and infection disease at Pune Hospital and Research Center and a Noble Hospital, Pune. An MD in internal medicine with over 12 years of experience. He has been actively involved in clinical research and care and treatment in HIV infection across individuals and territories in the hospitals in Western India. Dr. Dravid is a member of American Academy of HIV Medicine, AIDS Society of India, International AIDS Society, IAS, and European AIDS Clinical Society. We are talking about a very important topic, NIPAH virus, the recent scenario in India. And we welcome you in CMAAO International Weekly Meeting. Sir, over to you.
Thank you, Saurabh, sir. And today we are going to talk about a very important topic. I'll share my slides now. Please let me know if they are.
Just before we start the session, I would like to open the session for everyone. If anybody would like to join the session, can come on Zoom at 818-8591-1572. That's a Zoom ID. It's 818-8591-1572. If you have any questions, please ask in the chat box and we will be able to ask our expert. Thank you.
So thank you, Saurabh, sir. And today we are going to talk about NIPAH virus, recent scenarios in India. I work in Pune, which is very far away from the epicenter of the NIPAH outbreak in India, which is West Bengal and Kerala. But I reside in the city which does most of the BSL-4 testing for NIPAH, which is the National Institute of Virology, Pune, which gets almost samples referred from all over the country for diagnosis and final diagnosis of NIPAH. So over the next 30 to 40 minutes, I would like to give you an overview about the NIPAH scenario in India and what physicians and general practitioners and even laymen can learn about this evolving and upcoming zoonosis, which might become very important in the future. So why are people alarmed? Is because on January 26th of January 2026, WHO put out a bulletin saying there were 2 lab confirmed cases of NIPAH virus in West Bengal state. West Bengal state is on the eastern coast of India. Both the patients were healthcare workers in the same private hospital, and their samples were confirmed for NIPAH virus at National Institute of Virology, Pune on 13th of January. So it was a lab confirmed, PCR confirmed case of NIPAH virus. And this was the third NIPAH outbreak in the state of West Bengal. Previously, it was reported in Siliguri in 2001 and Nadia in 2007. So this was the third outbreak which was reported of NIPAH virus in West Bengal. Going deeper down, it was found that both the cases were positive for PCR and ELISA testing. The first case was a female nurse. The second case was a male nurse. Both were between 20 to 30 years of age from the North 24 Parganas district. Both cases developed symptoms typical of severe NIPAH virus infection, and they were admitted to the hospital in January 2026. As of 21st of January, the second case, the male nurse, has showed clinical improvement, while the first case remains under critical care. Following these 2 cases, the Indian health authorities tested all the contact persons, including all healthcare workers and community contacts in the hospital, in the community. Almost 190 contacts were tested. These 2 cases were put in isolation, and to the last moment, there are no more cases reported from India or from West Bengal which were NIPAH positive. So As of now, we have only 2 cases reported of NIPAH, but it did create an alarm because Southeast Asia, which is very close to India, these cases have been detected earlier, and hence China, Malaysia, Indonesia, all these countries where Singapore, they started raising alarm and started surveillance of patients coming from India to rule out Nipah virus. So this is the news item from which we are now going to go back and look at Nipah, its origins, how a small amount of science as to what this virus is, what it does, and what has happened in India in the last 20-25 years since Nipah has been showing outbreaks in India. So NIPAH is a virus belonging to the Henipavirus genus. It's a paramyxovirus family. It is the only virus along with Hendra in this family which causes zoonosis. Its main clinical manifestations are respiratory, that is ARDS, and neurological, that is encephalitis. The name NIPAH comes from the village of Sungai Nipah in Malaysia, near Kuala Lumpur, where the first cases of NIPAH were detected. The course of the disease, if not identified early, is very serious and it leads to death, with death rates almost ranging between 70 to 80%, because of which all countries are worried. The WHO has put out an advisory, and that's why we need to nip this outbreak in the bud. The natural reservoir of this virus are frugivorous bats called as flying foxes belonging to the Pteropus genus, and these flying foxes are found very frequently in tropical rainforests, especially in the state of West Bengal and Kerala in India, and similarly tropical rainforests all over Southeast Asia, because of which certain outbreaks have been reported in the last 20 years in Southeast Asia as well. It does cause spontaneous disease in human beings, pigs, horses, dogs, and cats. And main Nipah virus outbreaks have been reported from Malaysia, Singapore, Bangladesh, and India. So I will be talking more about the Bangladesh and the India outbreaks because we are neighbors, we are very close to each other, and the viral outbreaks are more or less having the similar course, and they also belong to the same family. So this is what we know about Nipah. This is the virus which we are going to tackle. So this is a single-stranded RNA virus. You can see the nucleoprotein inside, the matrix protein, and this is the fusion protein and the attachment protein through which the virus enters into the cell, respiratory epithelial cell or the dendritic cell in the brain. So it targets this receptor, ephrin B2. As we know, when we studied COVID, it targeted the angiotensin converting enzyme 2 receptor, while Nipah virus targets the ephrin B2 receptor. And this ephrin B2 receptor is mainly expressed in the endothelium, the brain, the lung, the placenta, and the prostate. And because it is present in large quantities in the lung and the brain, that's why we see more commonly ARDS, that is acute respiratory distress syndrome, and encephalitis occurring in Nipah virus outbreaks. Nipah virus can survive in palm date sap, the palm tree, which is very common in Kerala and West Bengal. Its date sap, which is licked by the bat, it can stay within it for almost 7 days. And it also resists in the urine of the reservoir bat for almost 18 hours. But this virus can be inactivated by common disinfectants like sodium hypochlorite, and also it cannot survive at high temperatures, that is more than 100 degrees Celsius. What is the host? As I said, flying foxes or fruit bats are the ones which are involved in NIV spread. These are the bats which contaminate palm fruit or palm sap. Or sometimes if you come in contact with urine or stool of the bat, there are many tourists which go in on adventure tourism. They visit caves in which these bats reside. And if you come in contact with urine or the stool, you can also get infected. Naturally, human beings are only spillover hosts. They are not naturally infected, but domestic animals like farming pigs, especially in Malaysia, where the first epidemic was reported, it was reported amongst pigs first. And you know, in Malaysia, there are huge pig farms and then there are pig slaughterhouses. So it is the pigs which fell sick and then it got transmitted to human beings. So pigs, horses, cats, all these do get infected. The farm animals do get infected, and from there the spillover goes on to human beings. So first the bat, then the intermediate host, then goes to human beings. Sometimes it can directly go from bats to human beings. So natural transmission occurs and from pig to pig and human to human transmission can also occur. So once this virus is introduced into the human population, and if we don't take correct infection control measures or we don't isolate the cases properly, then human to human transmission via droplets or via fomites can also occur. And hence it is very important to identify and isolate the patient at the earliest. So human beings are only spillover host. Remember that. And majority of the time, NIPAH contaminated palm fruits, which are also the sap is converted into alcohol in states like Bengal and Kerala and drunk. If it is not warmed up or it is just drunk like that, the virus can get transmitted to human beings. Similarly, these palm fruits can be eaten by pigs and horses, and that way it can get transmitted to these intermediate hosts. So there are multiple ways in which human beings can get affected. In Malaysia, Indonesia, or other Southeast Asian countries where pig farms are large, there it occurs via pigs, but the main host is bat. While in India, it is occurring from bat directly to human beings. That is the hypothesis. So this is the bat, which is the reservoir. And remember, this bat gets a subclinical infection. This virus does not kill the bat, because of which it can stay as a reservoir for years together. And that's why eradication of this NIPAH virus is virtually impossible, because the bat develops good immunity against the NIPAH virus, which lead to only subclinical viral replication within the bat. And that's why this spillover keeps on happening. And that's why we keep getting outbreaks once every 3 or 4 years in areas where this virus has been introduced, especially West Bengal and Kerala in India. So you can see these are the countries which are affected because of NIPAH. And this is India. You can see here, this is West Bengal, which is the first state in which NIPAH was reported. It is very close to Bangladesh, which also reported NIPAH virus outbreaks. And Kerala is somewhere here, and I will tell you in my next slides how the Kerala epidemic was different from the West Bengal epidemic. And this is where now the cases have been reported. So West Bengal is almost here, Bangladesh is here, and this is where in January 2026, India reported 2 cases of NIPAH virus outbreak. As you can see, wherever the Pteropus bat is going to fly, there you are going to see cases. And that's why Southeast Asia, sometimes even Australia, because horses in Australia were infected, and from horses, this virus got transmitted to human beings, because of which this Hendra virus was diagnosed in Australia as well. So wherever the Pteropus bat goes, tropical rainforests are there, spillover is going to happen to human beings, and that is where NIPAH virus outbreaks are going to happen. So what happened in Malaysia, I have already told you, it got infected via pig farms. There were pigs who may have eaten the palm fruit, because of which they got infected. And then these pigs were taken to slaughterhouses, from which pig to man transmission occurred. And then man to man transmission occurred, because of which there are almost 70 cases in Malaysia. And that time, the mortality rate was almost 70%. So if it is not diagnosed in time, it can really kill you, because of which early identification is very, very important. In Malaysia per se, it was bat to pig and pig to human being, and then human to human transmission, which amplified the epidemic. Moving on to Bangladesh, because it is very close by, it is our neighbor, and the epidemic in India closely mirrors that of Bangladesh. This was the first time Bangladesh reported the cases of NIPAH virus. The main route of transmission was consumption of raw date palm. Outbreaks normally coincide during harvest season of the date palm, and this date palm is licked by the bat. And if you take that sap and drink it, you can get infected with NIPAH virus. As I said, this is collected during December to May, and that's why these cases are detected in December to May. Once you get infected, human to human transmission occurs very fast. It is transmitted through droplets, and its RNA is found in the saliva of the patients. Once these patients land up in hospital, healthcare professionals are highest at risk, because many times in hospitals during the COVID pandemic, we were using universal safety precautions, we were using masks, we were using PPE, but now nobody in our hospital uses this. And hence, if the patient coughs or sneezes, if your hospital is poorly ventilated, healthcare professionals can get infected, and fellow patients can also get infected. So there were instances in Bangladesh and in Kolkata as well, where a patient had come to the hospital for poisoning and got infected with NIPAH and got seriously ill because of NIPAH. So if you don't, there is crowding, there is uncontrolled flow of visitors, there is poor hygiene practices, there is no hand washing, no masking, no PPE use, then it can spread from one index patient to the hospital, to the healthcare staff, and from healthcare staff, it can spread to other patients as well. So this was what was seen in Bangladesh. Then we come to Siliguri, West Bengal in 2001, where first time this was reported in India. Where is Siliguri? It is there in West Bengal. It is almost a center with a population of more than 5 lakh. It borders China, Bangladesh, Nepal, Sikkim, and that's why all these countries are on high alert today, because the cases can easily transmit there. In 2001 in Siliguri, patient 0 was never identified. So who got infected first was never identified, but he ended up getting admitted to a district hospital and infected 11 patients in the hospital. So you can see how fast it spreads. These patients then got transferred to other hospitals, generating more cases. Almost 25 healthcare workers and 8 visitors got infected. So this is what happened. So in India, the pattern has been that we could not identify the index patient, but once the index patient came to the hospital, maybe died, we don't know the cause was not identified, he transmitted it to the healthcare staff, who were probably, their guard was lowered, they were not masking, there was too much crowding in the hospitals, so they got infected, and from there on they transmitted it to other healthcare workers. So human to human transmission does occurs via droplets, occurs in patients when you tend to patients who are seriously ill, who are coughing and sneezing, who have ARDS, and from there on, if you get the infection, you can transmit it to others, especially the close relatives of patients or other patients in the hospital or other doctors in the hospital. So the outbreak of fever with altered sensorium began in late January 2001 and peaked in mid-February. This is in Siliguri in 2001. After February 23, no cases were reported. All the patients were residents of Siliguri, and clustering of cases was observed around one hospital, since staff of the hospital resided in that area. Based on the case definition, 66 cases were identified, and the case fatality ratio was very, very high, almost 74%. So you can see very high case fatality rate. The outcome of 61 cases were known, and 5 patients were discharged against medical advice. All patients were more than 15 years of age. So exclusively, it is an adult-only disease. The male to female ratio was 1.4:1. 75% of the 60 patients had a history of hospital exposure, and they were members of the staff or had attended to the patients in the hospital. The outbreak began at a single hospital, then went on to 3 other hospitals, and 5 families had more than one case. So multiple people in the same family were affected, and you can see these illnesses also, the onset was within 2 to 3 days apart from each other. So this is what happened in Siliguri in 2001. What were the symptoms? Fever, headache, myalgia, vomiting, altered sensorium, almost 97%. So it started with fever, headache, myalgia, just like any other viral illness, and then proceeded to confusion to coma. Almost 50% developed ARDS. So they had pneumonia, ARDS, breathlessness, on ventilator, and they had encephalitis. So respiratory symptoms and encephalitis symptoms. They also had involuntary movements, especially segmental myoclonus and convulsions. They had abnormal plantar reflexes, and you can see out of the 13 patients which were reported, 10 died within 2 weeks. So the mortality was very, very high. When they did the CSF, because in 2001, MR imaging was not very, very frequent in India, they found that the CSF was almost normal. However, CSF pressure was very, very high. So this was the symptoms which were first reported, and this is when it created alarm, because 60 patients were identified and there was a 75% mortality rate in Siliguri. So before the outbreak, when the epidemiological investigation started, they found that the staff in the hospital were not routinely using personal protective equipment or PPE, neither were they practicing barrier nursing. Use of surgical masks was minimal on wards. Certain universal precautions like hand washing and use of gloves were not adhered to. Patients were housed in wards with more than 4 patients in a single room. And plus family members could also visit those rooms. So it was complete overcrowding. Patients did not wear masks on wards, and when they were transmitted for X-rays, sonographies, or other investigations, masks were not used. Similarly, disposal of biomedical waste, collection of soiled linen, laundry, cleaning of floors was not done as per infection control practices. This was before the cases started piling up, and then the authorities woke up. They sent the samples, and that time PCR was not a very used investigation. So they sent IgM and IgG ELISA. Of the 18 patients whose samples were sent, all of them came positive for IgM and IgG ELISA. Some of the samples, that is blood, urine, throat swab, and CSF, were also sent for PCR, and those 7 patients for which RT-PCR was sent, they also came positive. On epidemiological investigation, it was found that the Siliguri sequences were similar to the Bangladesh sequences, and they were slightly different from the Malaysia sequences. So whatever epidemic was happening in Bangladesh, the same virus was getting transmitted to neighboring Siliguri in West Bengal, and the cases were piling up in 2001. What were the similarities we found between Bangladesh and West Bengal outbreaks? There was no intermediate animal host. So like pigs in Malaysia, there was no intermediate animal host. No sample that time was collected from local wildlife or domestic animals. So the bats were not tested, cats were not, dogs, nobody was tested. Major transmission occurred in healthcare settings. Only adults were affected, mostly because children are not allowed to go to hospital, because of which minimal children contact, and hence children were not infected. NIV was present in respiratory secretions and urine in both outbreaks. Because of failure of use of personal protective equipment, it contributed to spread of the virus. Especially many patients who had coma, they had nasogastric tubes inserted, or they had endotracheal tubes inserted, which led to aerosol generation and transmission. And inadequate barrier nursing was the main method, because of which we could not curtail the further spread of infection. Given the distribution, given the closeness to Bangladesh, it was identified that maybe the fruit bat is the one which is transmitting, and the spillover has happened to human beings. So we know this much. What are the other factors which can be linked to transmission? And they have found more factors, especially during post-mortems or when the person is dead. The close family members come in India and touch the face of the deceased, because of which the virus remains in post-mortem respiratory secretions and they can transmit it. Also, there are certain rituals where you don't use gloves or masks when you touch the face of the deceased person, or there are certain rituals like bathing the body. During that time, the water can get contaminated, and even that can serve as an important source of contagion. So it is very important to sensitize the population that there might be a NIPAH outbreak going on in your community, and hence disposal of dead bodies, although should be tried to sticking to the rituals and the religious practices which are already practiced, but there should be a change so that the post-mortem respiratory secretions don't transmit the virus to the close relatives. Other risk factors are, people say that not just date palm, other trees can also be licked by the bats, like mango tree, guava tree, lychee trees, and eating these fruits without proper cleaning, directly raw, can also lead to transmission to human beings. In the Kerala, there is no date palm, but there is coconut palm, which is used to make toddy, which is a popular alcoholic beverage. If you don't take proper sterilization techniques and you just drink the toddy raw, it can also lead to a transmission of NIPAH virus. Similarly, there are recreational activities, adventure tourism, people going into caves, and these caves are inhabited by these bats, because of which these urine and stool, they can come in contact with human beings and lead to transmission of NIPAH virus. So this is all we know today, right from droplet aerosolization to handling of bats, to their urine and feces, to drinking date palm, fruit beverages, which can transmit it to human beings, or it can get transmitted from intermediate hosts. But these intermediate hosts like pigs, horses, and cats are not present in India. They are present in Southeast Asia, especially Malaysia, Philippines, where these epidemics has been reported. Once it goes to the human being, it becomes a super spreader event if that human being gets admitted to the hospital and then starts transmitting it to others, if proper infection control practices are not practiced. What is the climate reason? People ask why this is happening. So this is happening because of habitat loss. Remember, bats have a main use in society. They are there in tropical rainforest. They are responsible for spreading of seeds of fruits, because of which new fruit trees can get these things. However, if there is rampant deforestation and rampant climate change, then these bats are going to move from tropical rainforest to human dwellings, because of which this spillover of the virus comes from bats to human beings. This is normally exaggerated in El Nino cycles, where there are warmer and drier conditions in summer, because of which the bats, because they don't have enough to eat, they go to human dwellings, they go to coconut trees, they go to date palms, start licking those fruits, and these fruits then fall down and get eaten by human beings, because of which climate change, deforestation, bats moving into human dwellings are the reason why these viruses are now coming as into human beings as spillover hosts and then getting transmitted from human to human. What is the pathogenesis of the virus? It enters the host via the oronasal route, causes infection. From there, it goes to the Walde's ring, the oropharyngeal lymphoid tissue. And after initial viremia, it spreads to bronchial epithelial cells. It goes through the blood-brain barrier. It goes to the dendritic cells. And there it starts an immune response, just like COVID-19. And the main interleukins, that is interleukin 6, interleukin 8, GCSF, they start crowding in, leading to a lot of inflammation into the lungs, lot of inflammation into the brain, because of which encephalitis and ARDS occur and the patient succumbs to the infection. So bridging of blood-brain barrier, going through the respiratory epithelial cell, causing pneumonia, ARDS, causing encephalitis is how the virus kills you. So you can see here, goes through the oronasal route, goes to the lung, activates an immune response, leads to ARDS. Goes to the brain, activates an immune response, causes fever, headache, leads to encephalitis, meningitis. Not just chest and brain, it can also go to kidney, heart, and as I'll show you in the Kerala part of the epidemic, that even a lot of patients came with myocarditis. And then ultimately it progresses to multi-organ dysfunction syndrome. So for the first 7-10 days, there is viremia, when you have symptoms like fever, headache, dizziness, myalgia. But once this virus enters the brain, enters the lung, starts an immune response, starts an exacerbated immune response, that is when you start getting these complications of ARDS and encephalitis. Now we move to Kerala, because this is the Bengal story. That is how we knew. In 2001, there was in Siliguri. Then there were small outbreaks in 2004, 2007. But the main turning point came when Kerala started reporting in 2018, first time, the Kerala, which is another coastal state, but this time on the western border of India, which started reporting cases of NIPAH virus in 2018. So you can see this is Kerala state. This is, you can see here, West Bengal is somewhere here. 2000 kilometers is the distance between West Bengal and Kerala. In West Bengal, we reported in 2001, 2004, 2007. And in Kerala, after almost 11 years, they started reporting the cases in 2018. Again, Kerala is a coastal state. This is the tropical rainforest. And you can see over the last 4 or 5 years, Kerala has reported multiple outbreaks, especially here in Kozhikode district and in the Perambara district as well. So these are the areas where this has been reported. So this was published in Clinical Infectious Diseases in 2018 about the clinical manifestations of NIPAH virus in patients who presented to the emergency department in Kerala state. Remember, West Bengal, Kerala is one of the best state as regards health indicators in India. It has health indicators which rival that of any Western country like Japan, Korea, United States, and that's why even the Indian government was surprised why so many cases started being reported in such a state which had excellent health indicators up till now. So we found that the median incubation period in Kerala was about 10 days. In fatal cases, they stayed in hospital for maximum 4 days, but in almost 2 days, majority of the patients died. The case fatality rate was 83.3%. So you can see that this was killing the patients very, very fast. If you look at what happened, you can see here the duration of fever was a median of 4 days. Incubation period was 10 days. The duration of illness was 6 days in fatal cases, and hospital stay was only 2 days. So you can see what has happened in Kerala. If you look at the symptoms, more or less the symptoms were similar: fever, vomiting, headache, cough, breathlessness, altered sensorium. But there were other indicators as well. Kerala started reporting that there was thrombocytopenia in patients. There was LV hypokinesia on echocardiogram. There was bradycardia, hypotension, requirement of inotropes. So myocarditis started getting reported in Kerala for the first time. So we already knew about encephalitis. We already knew about pneumonitis. Now we started reporting the myocarditis as well. So What were the syndromic manifestations? Encephalitis, ARDS, and myocarditis were reported. 10 patients each had encephalitis and ARDS. The two non-fatal cases, only two cases you have survived. So if you had encephalitis and ARDS, then your mortality rate was almost 90%. While if you didn't have both, you had either encephalitis or ARDS, then 50% of these cases could survive. Myocarditis was present in almost 5 patients. So encephalitis and ARDS together, almost 90% mortality, either encephalitis or ARDS or none, 50% mortality, and myocarditis also seen in 5 patients. So this started getting reported, and because Kerala has excellent health indicators, excellent health system, we could learn much more about the epidemic than we could learn from the Bengal epidemic, which was there in 2001, 2004, and 2007. Other neurologic manifestations started getting reported. Severe signs of medulla oblongata dysfunction, abnormal pupillary reflexes, seizures, segmental myoclonus, meningitis, diffuse encephalitis, focal involvement of medulla oblongata, cerebellar signs were getting reported. And there was another unique feature that this encephalitis, which has happened, can relapse even months or years later. So relapsed NIV encephalitis also got reported in Kerala, although the relapsed NIV encephalitis was not transmissible, just like the index episode. And there were psychiatric manifestations as well, like depression and personality changes also start getting reported. For the first time, Kerala reported that if you use antivirals, then there is a reduction in mortality of almost 20%. And ribavirin was a non-specific antiviral, which is reportedly used in multiple viral infections. Kerala reported the first use of ribavirin. Out of empirically being tried for 6 patients, 2 of them survived. And they said that although it did not meet statistical significance, they felt that ribavirin could be used as an antiviral for the Nipah virus epidemic. So what were the lessons learned? In Kerala, just like what we learned in Bangladesh, encephalitis, ARDS, and myocarditis can occur together. If you have encephalitis and ARDS, then the mortality rate is very high. Respiratory involvement is quite common, and it is just like the Bangladesh strain. Almost all, this time Kerala used a lot of PCR tests because PCR techniques had become quite refined, and hence all of them came positive for PCR. The samples like throat swab, blood, urine, CSF, all were sent and that came positive. They tried to use antiviral drugs like acyclovir and oseltamivir, no use. Ribavirin was used during the later stage of the outbreak, and it was found that the mortality rate reduced by almost 20%. In Malaysia, they also used ribavirin and they found that the mortality rate reduced by almost 36%. So there was one hope that maybe if we identify early, isolate early, and use antivirals early during the viremic phase of the epidemic, before the inflammation has set in, before all the hell has broken loose, there using the ribavirin could be helpful. So all cases were identified except the index case. So typical of Bangladesh and India, we could not identify the index case. The disease transmission ended immediately once barrier nursing was instituted. So initially, before we could identify that these encephalitis cases are because of Nipah virus, we were a bit confused. But once we identified it, we isolated the cases and barrier nursing was practiced, the disease completely stopped. So identification early, isolation early is very, very important. 11 of the 12 cases described were because of nosocomial transmission, which happened in a span of just 2 days. And spillover of the virus from non-human source, that is from bats to humans, happened only once. But from human to human happened multiple times. And remember, the delay between disease onset in index case and recognition of nosocomial transmission was 20 days. And because of these 20 days in 2018, multiple lives were lost in Kerala. The Kerala government immediately learned this correct lesson that we need to identify these cases early. Otherwise, there is very, very high mortality. You can see here, if the case fatality rate can even reach 100% if you did not receive any antiviral medication. But once you started using ribavirin more preferably, then it came down to 54%. Look at the R naught, it was 4.17. So one human being can infect 4 people. And if it is not isolated, if that person is not isolated in ward, he can infect up to 13 people. So it is humongously transmissible because the patient is bad, he's coughing, he has severe pneumonia. And if you don't practice universal safety precautions, don't use masks, don't use hand washing, don't isolate the patients, one person can infect 14 people at one go. So it is, and plus it's fatal. So we need to identify this early. We also then they released the MR imaging of these patients, and you can see here subcortical infarcts or white matter lesions are seen in the subcortical area in early NIPAH encephalitis. You can see here these are the infarcts. So we started having MR imaging as well of NIPAH virus encephalitis patients. And in relapsed NIPAH virus, that means those second episode of NIPAH which occurs months to years later, then even the cerebral cortex got got affected, and there was severe cerebral edema which lead to death of patients. So parietal lobe involvement, this all occurred in relapsed NIPAH encephalitis, while early NIPAH encephalitis there are only infarcts in the periventricular area. Further outbreaks. So now once it gets established, as I said, the bats are they have subclinical disease only. So spillover is going to occur. Once it gets introduced into the population, having Nipah virus outbreaks is a given. So early identification is the key. So once it got introduced into Kerala, then it started having yearly or twice yearly outbreaks. So in recent outbreak in 2023, there were 6 cases, but this time there are only 2 fatalities. So Kerala learned its lesson. Similarly, in June 2021, 2024, there were only single cases. So they had identified the cases so fast that once the first case was identified, they immediately isolated the patient, and then the transmission completely stopped. So Kerala was on high alert. Any patient with acute encephalitic syndrome or pneumonia was immediately isolated, because of which the cases were identified, and then immediate isolation was done, which led to much lesser cases. Similarly, they found that the Bangladesh and India, why? Because the case fatality rate is more than 70% in India. So we need to identify these cases. Just in Malaysia, they had only encephalitis syndrome, but in India, they had pulmonary plus encephalitis syndrome and had high chance of human-to-human transmission. So the Bangladesh and the India variant was highly pathogenic. They had very high viral load in secretions. They had shorter incubation period and higher mortality rate, because of which identification had to be fast, and Kerala did a very good job by identifying the first case and isolating the patient, because of which transmission became virtually impossible to other people in the. Kerala also started educating the public not to consume fallen or bitten fruits, avoiding consuming nectar in banana flowers. Banana leaves are used for eating food in Kerala. They clearly said that you have to wash those banana leaves before food materials are sold. Wash your hands in case of any accidental exposure. Don't drink unpasteurized date palm sap or coconut palm sap, which is toddy, and avoid naturally available sugary drinks like nectars or fruits or fleshy carbs, which can be licked by bats. So Kerala started educating the public as well. Similarly, to avoid hospital transmission, suboptimal infection control measures and limited isolation facilities, as I said, are fertile soil for NIV transmission. The avoidable spread of hospital infection far outnumbered the spillover infection. Though the spillover infection is only 1, but hospital transmission and human-to-human transmission is almost 1 to 14. That has to be avoided. Once you isolate the patient, you end up with 0 transmissions. And that is what is very important. Early detection is very important. Once you detect it during the viremic phase and give non-specific antiviral drugs, then you decrease the case fatality rate. And hence, diagnosing Nipah encephalitis at acute viremic phase is a priority. So, in Kerala, what happens now? All encephalitis cases undergo a PCR-based panel of investigation, which includes dengue, measles, Japanese encephalitis, herpes encephalitis. All these samples are negative. Then the samples go to a BSL-2 lab, or there is a new nucleic acid test which is done by an Indian company which is called as TrueNat, which looks at a viral panel for diagnosing viral encephalitis. If any of these tests turn positive, they are sent to the BSL-4 facility in Pune, where I am based, and then Nipah is diagnosed. So now Kerala state has almost 5 PCR facilities and 2 TrueNat facilities. The government of Kerala is now planning to deploy TrueNat-based point of care facilities to all the centers. The clinicians and radiologists are trained in Kerala to pick up segmental myoclonus and discrete high-intensity lesions in brain, because of which encephalitis can be identified early, Nipah can be diagnosed early, and immediate treatment has been started. And because no approved treatment measures and there is high risk of mortality, Kerala state has approved broad spectrum antivirals on compassionate grounds. Which are the two? 2018 they used ribavirin, but as you know, by 2020 remdesivir had come into being, it was used for COVID extensively, and remdesivir, as you know, was initially used for treatment of blanket RNA viruses. It was used first for Ebola, then for COVID, and now it has been believed that remdesivir, which can be given on compassionate grounds to people of NIPAH encephalitis, has helped in improving the case fatality rate. This has been recognized by US CDC and European CDC as well, and they have recognized the potential role of remdesivir and ribavirin in NIV outbreaks. So the Kerala State Medical Board has now made a blanket recommendation that once NIPAH is suspected and you have sent the samples for a diagnosis of NIPAH, remdesivir should be started, 200 mg loading dose and 100 mg daily for 12 days treatment. And if there is high risk of contact with family member or to the healthcare worker, favipiravir, which is another antiviral which was used during COVID times, can be used as prophylaxis on compassionate grounds amongst high-risk primary contacts. Remdesivir and ribavirin are the true drugs the consultants in Kerala believe have helped when used early on compassionate grounds to reduce the mortality in patients of NIPAH virus. There is another monoclonal antibody which is under trial, but it has very limited availability and not available in India. So, was there any panic surrounding NIV outbreak in Kerala? Of course there was. People used to cut down trees. They used to burn the trees so as to scare away the bats. But remember that if you cut down trees or you scare away the bats are going to go into human dwellings. The chance of NIPAH virus spillover is going to increase. There is going to be a vicious cycle, and hence we should discourage this. So initially there was a panic. People used to start burning trees, burning bat habitats, and then the bats used to come into the human dwellings, and then it used to increase chance of spillover. So that was completely stopped. Forest exploration and adventure tourism was put on hold for some time because people don't respect bat habitats. And remember, bats are essential because they are the ones who transfer the seeds. They are the ones who transfer the seeds from one place to another so that the tropical rainforest can grow. They have a position in the entire food chain, and hence by rampant cutting of trees, these bats are now spilling over the disease into human beings. The fruit market had completely collapsed. So not just bananas, not just date palm, people had stopped eating areca nuts and cashew nuts as well, and hence their education was also very, very essential. So all these things were done by Kerala so that, and as I said, in the last 3 or 4 times when Kerala has reported a single case, isolated the case, identified NIPAH encephalitis early, started antivirals early, isolated them early, because of which only single case was diagnosed and transmission was completely stopped. So why are we worried? So even now, West Bengal has reported only 2 cases. Those 2 are healthcare workers. Maybe the index case was never identified. Those 2 have been isolated, and there have been no more cases. But remember that this NIPAH virus is transmitted through exposure to body fluids, respiratory droplets, to people of close contact. And just like SARS-CoV-2, NIV can also acquire favorable mutations. And if it acquires favorable mutations, just like SARS-CoV-2, and if it starts, now it is droplet transmission, but tomorrow if it acquires aerosol transmission, it gets chances to evade body's immunity, then it can really cause a pandemic, because of which WHO has included NIV in the list of priority pathogens and called for global investment towards research and development. Ribavirin and remdesivir should not be the last antivirals which we hear of for treatment of NIV. And remember, just isolation can do the job, but tomorrow if it becomes more prevalent, more easier for the NIPAH virus to transmit, then we might look at a pandemic as well, and hence the world should be worried. Hence those 2 cases reported in January 2026 from Bengal has caused alarm in Southeast Asia, especially China, Singapore, where Singapore Changi Airport has put up again the terminals for diagnosing fever amongst passengers coming from India so that they can be screened fast and the NIPAH virus can be identified early. So this is why the world is worried. So in conclusion, this is my last slide. NIPAH virus is considered an emerging pathogen responsible for zoonosis because it has high mortality. Whether it will cause a pandemic in future, nobody knows, but high mortality rate upon infection and its acute course makes the disease very difficult, especially in countries with weak economies. Remember, weaker countries, poorer countries, if they don't have facilities of PCR, if they don't have facilities for good isolation and human-to-human transmission occurs fast, then there might be multiple cases with very high mortality. We don't have a specific treatment, we don't have effective prophylaxis, and we are not going to eradicate the NIPAH virus because subclinical infection in bats is going to remain. The bats don't get any symptoms, so they don't even know that they are transmitting the virus, and they are spilling it over into human beings, or they are spilling it over into intermediate hosts. The virus tends to evolve into new variants. As I said, the Malaysia variant was causing only encephalitis, while the Indian variant caused encephalitis and ARDS, and then later on now even showing myocarditis as one of the feature. So it is evolving into new variants, and climate change is going to complicate this by potentially driving the viral evolution and increasing human transmission. So early detection and prevention of human to human transmission by isolation is very, very important. Ongoing surveillance of bat population is very, very important. Monitoring of all acute encephalitis syndromes, especially in where outbreaks have been reported, and death audits has to be carried out. Investments in research for new vaccines, monoclonal antibodies, and antivirals are vital. And One Health approach where all of these things, animals, intermediate hosts, bats, human beings, climate change, deforestation, investment into PCR techniques, investment into new treatments, all these things, One Health approach, if taken, will be needed to tackle NIV outbreaks. Thank you, and I stop sharing here, and I'll take questions if there are.
Dr. Dravid. The full session. I think much needed topic. We would like to now open the forum for question answers. Anybody in the audience can write the question in the chat box or raise the hands. We have Dr. Chong, our chairman, and all other dignitaries from the other countries. Please, Dr. Chong, take over the session.
Thank you, Saurabh. And Dr. Ammet, thank you very much for the update on the Nipah virus. I'm from Singapore, and here in Singapore, there is quite a lot of publicity on the media about the Nipah virus. And we also receive extensive advice and guidance from our Ministry of Health. And you're right, the Changi Airport is also ramped up its surveillance. So yeah, I think the bad connection is quite frightening because COVID was also believed to have come from there. So quite alarming, but glad to hear that early detection and early isolation has been critical in stopping the spread of this virus. Thank you very much. Any questions on the floor?
Thank you, sir, for the very nice presentation. Can you please share the conclusion for a slide again? Actually, I have taken a few pictures. It will be helpful for me.
Yeah, I'll share it once again. Just wait. Can you see it?
Yes, sir.
So, Dr. Dravid, while you're sharing the screen, there's a question on the Facebook which says, are there any vaccines or research developments in progress for Nipah virus which are already available?
There is no vaccine available as of now. International Vaccine Alliance is working on an mRNA vaccine, but as you know, these vaccines take a lot of time. The manpower and the money required for investigating a new vaccine and the time taken is humongous. And we are not living in COVID times where vaccine was very easily could be taken up. So that is where the problem lies, and there is currently no vaccine as of now. So we have got to do with whatever we have.
Thanks. What precautions should a healthcare worker follow in managing such suspected cases, and what precautions should a global traveler should follow while he's traveling on various countries?
See, all healthcare practitioners, especially where outbreak has been reported, simple surgical mask is enough for preventing transmission. So all healthcare workers working in the ICUs, working in the wards, medical wards, working after patients of encephalitis, ARDS, simple medical mask is enough. If PP is available, great. But if PP is not available, N95 mask, surgical mask, because it's a droplet-based infection, and isolation of the patient into single room. We should not be crowding these patients into one room, and complete not allowance of family members to come and see the patient. They can do it on Zoom call, they can do it on WhatsApp call, but not to come and meet the patient. If we do this much, it is enough. And if symptoms are seen in healthcare workers, what was observed was that the healthcare workers reported their symptoms very, very late. When they were having cough, cold, myalgia, body ache, they never came forward. They came forward when they started developing dizziness, they went into coma. That's when everybody, the alarm was raised. So even in these two cases in West Bengal, the male nurse and female nurse both got admitted with acute fever, going on to convulsions, then into coma. And because of the prior experience of West Bengal with NIPAH, this was suspected and the samples were sent. So we should identify the cases early. All healthcare workers should practice masking, should practice hand washing. Now it is a universal precaution we are doing after COVID. COVID has taught us how much important hand washing is, how much important masking is, how much important isolation of patients is. For travelers, yes, if you are traveling to a country, so if somebody is traveling from, say, Singapore to West Bengal or from Singapore to Kerala, where just report cases have been reported, again, using a mask on the aircraft, using a mask when you go to crowded places, washing your hands often, and reporting simple symptoms like fever, cough, cold, myalgia, headache to the authorities there, because the authorities in the local places are the ones who are the best geared up to treat the infection. So I was also surprised that physicians and healthcare workers in Kerala are taught how to pick up segmental myoclonus, or they are taught how to pick up an MRI which looks like NIPAH encephalitis, which is an amazing thing to do, or were geared up for every acute encephalitis case to be looked at NIPAH virus, in addition to all other viral encephalitis which we test for. So this is a very, very good thing which we can identify early, isolate early, treat early. So ribavirin and remdesivir, these are non-specific viral agents, but they have brought down the mortality by almost 50%. So hopefully with new research, new antiviral agents coming in the next 2-3 years, hopefully we will have better drugs for treating NIPAH. So all these things are very, very important, and these need to be practiced. And in this era, we are not going to constrain travelers. People travel, people go ahead, but simple things hand washing and masking is enough for you to be safe.
I agree. Basics of, I think, traveling.
Yes, basics of hygiene.
Yeah. Dr. Monica, since you're from a similar field, would you like to make some comments over here?
Thank you, Dr. Dravid, for a fantastic presentation, and especially it's very timely considering the cases that you had detected in India. I think when you say about early detection, it becomes very confusing when you have non-specific early viral symptoms.
Yeah.
Any viral symptom, any viral infection would lead to those early symptoms, and to be able to have the high index of suspicion and the very, very well-trained eye, as you have seen, I think is what is needed to make sure. But you're not going to get CNS imaging and a person who's going to be able to identify those early signs. That combination is going to be very complicated when you have an early onset viral infection that could be influenza A, RSV, and even COVID. So I think what you've been able to accomplish by having these two cases contained is phenomenal. I think it's fantastic. It speaks to the medical system. I think it speaks to just how well you have all done, and I want to say congratulations for having it contained. It doesn't mean that you can lower your guard, but I think what you're doing is fantastic in terms of educating that this is what these symptoms are, making sure that we raise a level of suspicion across areas where even typically have not seen a case, and to make sure that everybody can contain this so it does not become the next major global issue. Thank you again for a fantastic presentation.
Thank you so much.
Thank you very much, Dr. Dravid. And one last comment is in Singapore, we used to have pig farms a long time ago. And so we have quite a bit of experience with Japanese encephalitis spread from that host. So I remember we used to have those cases, and those are quite horrendous, those cases. So glad that you guys are able to contain it so rapidly and so quickly. Because the outcomes are, I recall those Japanese encephalitis cases were very bad.
Yeah.
So thank you very much. And if there are no questions from the floor, then we've come to the end of our session. And I'd like to thank Dr. Dravid again for the wonderful presentation.
Dr. Chong.
Very timely.
Dr. Chong.
Yes,
Dr. Chong.
Dr. Sajat, yes. Yes,
I'm
Dr.
sorry,
Sajat, you have a question?
Yeah. Thank you very much. And I say that it's a very excellent and fantastic presentation, very knowledgeable, very informative. And I missed some points because I am in hospital in academic activity. But I have a question that I have two questions. How many patients are died in Bangladesh with this NIPAH till now, and in India and in Malaysia? Number one. Number two, that in corona we know that the transmission from human to human is through droplet infection, but not through liquid eating anything, isn't it? But as Dr. Amit said, that the infected liquid or any food, fruits, fruit bats, if anybody take it, can infect the Nipah virus. So, is this true, or how can we prevent the eating or drinking something, which is how can we diagnose that this is infected or not? Thank you.
So, first question was about the mortality. So,
Yeah.
in Malaysia, the mortality, it was clearly transmission from pigs to human beings, the mortality was 40%. The Malaysian variant was much less pathogenic than the Indian and the Bangladeshi variant. In Bangladesh in 2001, the mortality was 75%. So out of all cases identified, 75% died. While in West Bengal in 2001, the case fatality rate was 83%. So if 100 were identified, 83 died. So it was a huge killer that time. So that's why early identification and early isolation with time. Now, if you look at in West Bengal, two people were identified. One is already better. One is still in critical care. While in Kerala, they are reporting one case and then no more cases. So because of early identification. So now we have better antivirals, better infection control practices, because of which the case fatality rate has come down to less than 50%. I'm sure with just one case being identified or two cases being identified, it will be even lesser. Hopefully, we will have better vaccines. As Dr. Chong had said that we now have a Japanese encephalitis vaccine. Hopefully, we will have a NIPAH vaccine in the future, because of which then we will be able to vaccinate the endemic population from that. And second question was whether drinking of date sap or coconut palm sap can transmit. Yes, it can. But remember, the first infection which occurs from bat to human being is maybe via drinking of the sap, which is contaminated, or it is not properly cooked, it is not properly heated, drunk raw, or the fruit eaten raw without cleaning. So that is something which we can educate the public, that please don't drink anything raw, please don't drink raw fruits without washing. So, but once that infection occurs and once that index case gets admitted in the hospital, the next transmission is through the hospital only. So maybe one index case we have missed, but the next cases which have happened in hospital are clear cases of human to human transmission. And as I said, that this disease is residing in bats as a subclinical infection. So this spillover is going to happen in the future. Every 2 or 3 years, we are going to see 1 or 2 cases reported of NIPAH either from Kerala or from West Bengal, because this virus has been introduced into the population. How fast we control it, how fast we isolate those cases and not let other people get infected and not let our guard down, as Dr. Monica said, is most important. And then we can stop the epidemic in its tracks. So 1 case, 2 case is manageable. Hopefully in the near future, we will have better antivirals as well, so that we can treat them fast once it is identified. So early identification, early treatment, better vaccines. Yes, there is hope for the future. But as of now, we are where we are.
Okay, thank you very much. Can you say any working on the vaccine for NIPAH is underway or not?
Yes, sir. It's going on. But as I said, any vaccine which is under development takes years of effort. It is not, we are not in the COVID era where we could fast track vaccines. I wish.
Yes. Right. Right. Thank you very much, Dravid. Thank you.
Thank you, Dr. Sajat.
Thank you, John. Thank you, Chong. Thank you.
Thank you. And thank you, Dr. Ammet. So without much ado, thank you again for your wonderful presentation and most timely and very useful in view of all the news that we have even here in Singapore. And thank you very much for your session and much appreciated. We hope to hear from you again.
Thank you.
Everyone for joining in. See you and stay tuned for the next session. Thank you.